Hello, good morning, Anila. So we are going to discuss today um, MRCS Part A, Paper 2 topic, breast and endocrinology. So in this lecture, we'll cover the breast only. Yeah, we'll start with the breast. Uh, First of all, we'll just look for the nipple discharge. So the nipple discharge, it can be physiological. It can be breast, like milk discharge during breastfeeding, galacturia under the influence of any drugs or underlying pathology like pituitary tumors. Other conditions which can result in the blood stain discharge or pus discharge or other color, thick greenish discharge. So could be a cause of. They could be due to the any underlying uh, pathology like malignancies. So memory ductictasia is also known as plasma cell mastitis. So it is also known as plasma cell mastitis. Right. So it is seen in the menopausal woman, involves multiple ducts, right? Result in thick green cheese like discharge, most common in smokers. Carcinoma, it is present as a blood-stained discharge, and there may be association with the axillary lymphadenopathy. Intraductal papilloma, it is same like memory ductictasia, but it is common in the young patient. Single duct involvement, and it is not associated with the smoking. It is usually not present as a palpable lump, but some conditions under circumstances, there can be hyperplasia or lumpy conditions present. Okay. How we assess the patient? So patient assessment is done through the triple assessment. Triple assessment is always examination, imaging, and then intervention. Okay. Intervention like biopsies and further on. Okay, so in imaging, then we have, as we discussed in the triple assessment, we're going for the imaging. So in imaging, we have different modalities like ultrasound, mammogram, and MRI. Right? So it's an example how we assess the patient. If we're doing, suppose, mammogram, so we grade them M1, M2, M3, M4, M5. And M1 is there is no abnormality. M2, it begins with the benign features present. M3 is intermediate but probably benign. M4 is intermediate, probably malignant, and M5 is malignant. Right? How to manage the non-malignant nipple discharge? So first of all, we have to address the underlying issue, underlying cause. What is the underlying cause? We have to find out that. It could be any endocrinology related disorder, it could be inflammatory condition, any other pathology, right? First of all, identify the underlying cause and then go for the nipple cytology. It is with the non-malignant discharge, nipple cytology is not helpful in these conditions. Second, smoke cessation is the important thing, right? especially for the ductictasia. Right? Okay, we will discuss this when we discuss in detail the ductictasia. Gynecomastia. Gynecomastia is a abnormal proliferation of the breast tissue in males. Right? So it can be physiological and pathological. Physiological at the puberty. Pathologically, it can be a syndromic condition, any infection, right? It is also associated with the cryptorchidism, like testicular failure, descent into the scrotum, liver cirrhotic conditions, liver testicular carcinomas, especially seminoma, any ectopic tumor secretion, right? Can be related with prolactinoma, hyperthyroidism, hemodialysis, and some drugs. For the drugs pneumonia case, disco, right? So it is digoxin, isoniazid, spironolactone, calcium channel blocker, cimetidine, estrogen, right? This is a mnemonic for the drugs. Other drugs which rarely cause, so it's a combination of this. So I just combined this so you can just go through. So these are the drugs which were most commonly associated with the gynecomastia, and these are the drugs which rarely causes gynecomastia. Right. So the treatment option, first of all, identify underlying cause, treat the underlying cause. And if there is breast enlargement, so there are many surgical options. So we can go for liposuction for the best cosmetic outcome. Then we'll go for the malignant conditions, right? Cancer conditions. So it could be benign or cancers. So the malignancy can be benign or cancerous. So first of all, we go through the benign breast conditions. And breast condition is fibroadenoma, as the name indicates. So it will be a firm, mobile mass, right? It involves the whole lobule. 12% of all the breast masses, right? It includes. There is no risk of the malignancy with fibroadenoma, but it can be seen in patient with the adenosine sclerosis, right? Sclerosing adenosis, right? It can be seen with the patient with the sclerosing adenosis, the fibroadenoma. The most important part here, as it is not associated with the there is no risk of associated malignancy, or there is no risk of development of the malignancy. But if the mass is more than 3 or 4 centimeter, so we have to go for the biopsy and exclude phyloid tumor, which can be again benign or malignant. And then according to that, we go for the intervention. It can be white local excision or mastectomy. Then we come to the breast cyst. Breast cyst, as the name indicates, fluid-filled. These are lumps or cysts or pouches which are filled with the fluid. So that's why it is soft and fluctuant, right? And they on imaging, when we do ultrasound, it shows a halo sign, right? And on histopathology, it will show apocrine papillary projection. And fibroadenoma on histopathology, it shows popcorn calcification. Okay. So what we do normally when there is cyst present, and it is associated with the small risk of the breast cancer, especially if the patient is young. So what we do with the cyst? So we do aspiration of the cyst. But if it is blood stained or recurrent, we go for the excision. Coming to ductictasia, we discussed before, most common in menopausal women. Multiple, M for menopausal, M for multiple ducts involvement. Greenish, cheese-like, thick greenish, cheese-like discharge, right, with the nipple retraction. So if it is on ultrasound, if it is U1, go for the reassurance. But if it is U2, U3, U4, then accordingly we will treat the patient. If the patient is young, then we go for the microducectomy. An older patient, we go for the total duct excision, right? So menopausal women, we mostly go for the total duct excision, which is known as Hatfield procedure, right? Hatfield procedure. Sclerosing adenosis, right? Or fibrocystic adenosis. It is also known as fibrocystic adenosis. Can be seen in association with the fibroadenoma, also known as fibrocystic adenosis. Right? Again, it is usually present as a lump, breast pain. So on mammogram, so it causes mammographic changes which may mimic carcinoma. So it can, there's association of the carcinoma, risk of the carcinoma development. It causes distortion of the lobular unit, as name indicates, sclerosing, right? So distortion of the lobular unit. And right, so we go for the biopsy. An excision is not mandatory in this case, depending on the result of the biopsy, but excision is not mandatory. Okay, and it's not that important. Just remember that sclerosing adenosis or fibrocystic adenosis can be seen in patient with the fibroadenoma, right? Or fibroadenoma, and they're associated with each other. Fat necrosis is mostly traumatic, 40%. So physical features usually mimic carcinoma, and it can increase in size initially. So again, imagine and core biopsy, right? To exclude any carcinoma. And also, okay, most common in breastfeeding women as well, due to the, so it's called the bite, the baby bite, or strong suckling result in the traumatic reason. Okay, intraductal papilloma, we discussed it is young patient, single duct, blood discharge. So as we discussed, it is not present with the lump usually, but large papillomas may present with mass, right? If it is large, it can be present as a mass and single duct involvement. As it is present in the young patient, but it is not associated with the smoking. No smoking. As ductictasia, positive smoking history. Right? So for the young patient, we'll go for the microducectomy. And for the older patient, we go for the total duct excision or Hatfield procedure. And it is not associated with any risk of malignancy. Then we come with the periductal mastitis. Periductal mastitis, again, like the duct ectasia associated with the smoking, young patient, strongly associated with the smoking, and may present with the inflammation, features of the inflammations. So, if it is inflammatory, so it may present with the abscess or duct fistula. So, what we are doing, antibiotic and incision and drainage of the abscess. Breast abscess, again, the same, antibiotic, ultrasound guided aspiration or incision and drainage, right? And it will present as a flatulent mass. Most common organism is Staph aureus. So, yeah. Tuberculosis is a very rare condition, may present as a secondary TB symptoms. So, most common in childbearing age period, and axillary sinuses. So, chronic breast or axillary sinuses may present in 50% of the patient in these patients. So, again, the diagnosis is by the biopsy and histology, and then treatment with the ATT and excision of the fistula and all. Paget's disease of the nipple. So, Paget's disease, actually, it is the eczema of the nipple. So, it is eczema like skin changes or eczematous skin changes of the nipple. So, eczematous skin changes start at the nipple and going laterally towards the areola. So, from center to outward, from center to periphery. Normally, eczema start from the periphery towards the center. So, it is the opposite. So, this is the first sign, that is the Paget's disease. So, definitely it will be red, crusty, itchy, scaling, or bleeding rash on the nipple, right? Mostly this is associated with the ductal carcinoma in situ. Most common it is with this one. Also, you can see in invasive carcinoma as well. But most common it is ductal carcinoma in situ. Right? Then, yeah, we discussed this in diagnosis again. The triple assessment, everywhere the triple assessment. Right? Examination, imaging, and then biopsy and intervention and all that stuff. So the treatment is, it could be surgical, right? And additional therapies. So surgical, yeah. The primary treatment is surgery. It could be either breast conserving surgery or total mastectomy. White local excision. Right? Breast conserving and total mastectomy. Additional therapies, we can go for the radiation, chemotherapy, hormone replacement therapy, if there is an invasive disease. Right? Prognosis, if it is caught earlier, prognosis is good. Phylloid tumor, we discussed that if fibroadenoma is more than 3 or 4 centimeter, we have to go for the biopsy to exclude phylloid tumor. Right? It can be again malignant or benign. Malignancy always comes with the atypia, hypermitotic activity, hypercellularity, all these things that we discussed already. And it will be a painless enlarged breast mass more than 3 centimeter, massive size with uneven bocellated skin surface, reddening, male serum due to the pressure, no, but not infiltrative. And again, 2 types, benign and malignant. Then we come to the breast cancer, malignant breast cancer, right? So malignancies, there are two types. Okay? So in situ, invasive. So it can be ductal, lobular, ductal, lobular. So if it is in situ, so it can be invasive ductal carcinoma. In ductal carcinoma in situ, lobular carcinoma in situ. If it is invasive, then invasive ductal carcinoma and lobular, invasive lobular carcinoma. Pre-malignant changes, we know already, it is always associated with the hyperplasia, atypia, increased mitosis, right? So normally the most common is ductal carcinoma in situ, mostly is seen these one. It is also associated with the Paget's. Paget's can result, it is not associated, but Paget's can indicate the underlying ductal carcinoma. Okay. Then the invasive lobular carcinoma, invasive breast cancer, we discussed the invasive ductal or invasive lobular. It is mostly seen in postmenopausal, right? And mostly 15% present with the contralateral breast as well. So it can present 15% in the opposite breast as well. Also can be seen as inflammatory breast cancer and malignant phyloid tumor. Yep. Then we'll go through the carcinoma in situ. As we discussed, the most common is ductal carcinoma in situ. So here we'll just go through the subtypes. So it can, there are subtypes comido, cribriform, micropapillary, and solid. So the comido is present with the microcalcification, cribriform and micropapillary multifocal. Mostly they are mixed. High growth tumors, there will be loss of the tumor suppressor gene P53 and increased expression of the ORB2, right? Local excision, so like in low grade tumor, if it is a low grade tumor, we can go for the white local excision, which is a blood conserving surgery, and a high grade tumor will go for the mastectomy, total breast removal. After white local excision or breast conserving surgery, patients are offered radiotherapy to prevent the recurrence, right? Especially if it is young patient. Lobular carcinoma in situ, it is rare form, right? As we discussed already, that in situ, the ductal carcinoma in situ is most common. This is rare. No microcalcification. It has a single growth pattern, not like this, as it has comido, papillary, cribriform, solid, right? Again, it also can be low grade and high grade, right? So the low grade, again, it is monitoring rather than excision. And if it is axillary nodal involvement, so when an invasive component is found, it is less likely to be associated with the axillary nodal metastasis. So it is not associated with the axillary nodal involvement as compared to the ductal carcinoma in situ, which can present with the axillary nodal involvement, right? And it is mostly monitoring in the low-grade patient. Risk factors of the breast cancer. So age, genetic mutation, estrogen exposure, age and gender, we know. Mostly it can present in young patient with the positive family history, right? And associated with the increased age. Genetic BRCA1, BRCA2 mutation, which is a family history. Exposure of the estrogen, it can be endogenous or exogenous. Endogenous result from the long reproductive life, like it could be early menarche, early menstrual cycles, and late menopause. That can result in the endogenous production. So that can lead to the breast cancer. So, endogenous estrogen production. And then late first pregnancy or prolonged nulliparity. That can also result in the increased estrogen and result in the breast cancer. Exogenous, like oral contraceptive pills. Prognosis. So the prognostic indicators are the nodal status, size of the tumor, and tumor grading, which we assess through the Nottingham Prognosis Index, right? So Nottingham Prognosis Index, we assess all these three statuses and we identify the life expectancy and we give the prognosis, right? So if it is score 1, so it means there is no node involvement and it is grade 1. Score 2, 1 to 3 lymph nodes involvement in grade 2. Score 3, more than 3 lymph nodes and grade 3. So then if it is 2 to 2.4, 93% survival for the 5 years, 2.5 to 3.4, 85%. As the score increases, life expectancy decreases. As the score increases, life expectancy decreases. Breast mass, we discuss triple assessment. So first of all, examination, right? Then imaging, which include ultrasound, mammogram, MRI. Then intervention, which is biopsy. So different types of biopsy, right? Needle biopsy, which can be FNSC or core biopsy, core cut biopsy, right? Then we have punch biopsy. Then we have open, which is again excisional and incisional, right? So in FNSC, we just take a small amount of cell, while in core cut biopsy, it is a wide bore needle, and in this we take a sample tissue. It does not differentiate, the FNSC cannot differentiate between the invasive and in situ. So for that, we have to take a deeper biopsy, which is a core cut, so that can help in differentiating core cut, invasive or ductal malignancies. And other are punch biopsies and open biopsies, which can be excisional and incisional biopsies, right? Okay. Ultrasound we do in the young patients, less than 35 years. Mammogram we do in patients more than 35 years. MRI in high risk patients with implants or recurrence carcinoma, or for the monitoring purpose. Chemotherapy or radiotherapy response, right? So MRI in high risk patient, a patient with implants, high risk like family history, young patient, patient with implants, patient with a recurrent carcinoma, or for the monitoring purpose, response of the chemotherapy and radiotherapy in the patients. right. Yeah. So now we'll go further. These are all points we discussed. Yeah. Imaging again, as we discussed the mammogram before, if it's M1, M2, M3, M4, how we describe them. M1 with no abnormality, begins abnormality with the benign feature, then intermediate benign, M3, M4 is intermediate malignant, and then it is malignant. MRI we discussed, high risk women with the implants, response to check the response or monitor the response of the treatment like radio and chemo, and recurrent disease, right? And metastasis, yeah, for the metastatic disease. We can go through these points. Okay, lymph nodes. So first of all, we know the axillary lymph node. There are 3 levels for the axillary lymph nodes, which can be divided with the pec minor. So the level 1 is below the at the lateral border of the pec minor, level 2 behind the pec minor, and level 3 is the above the pec minor. And how the clearance we indicate? So the clearance, axillary clearance are again level 1, level 2, level 3. So in level 1, we remove the lymph node group 1. Level 2, we remove the group 2. And in level 3, we remove all the groups, including the axilla, apex of the axilla. Treatment options again, we have surgical, right? Radio, chemo, and hormonal therapy, right? And targeted therapy. So surgical, we discussed, we have 2 options: total mastectomy and white local excision, which is known as breast conserving surgery. So if it is total mastectomy or mastectomy, so it is why we are doing, because it is a dangerous condition, or it is a bad tumor. So like it could be multifocal, central, and large tumor, right? Ductal carcinoma and cytoma more than 4 centimeter. So we go for the mastectomy, and definitely patient choice is always the priority. White local or breast conserving, it indicates the breast conserving patient, the lesion is solitary, small, peripheral, less than 4 centimeter, and obviously patient choice. As we discussed before, that in white local excision, we always give patient the radiotherapy if patient is young, right? So we always go for the radiotherapy in young patient after the white local excision. Okay. Okay, these points we discussed already. Central lesion, large lesion, or always go for the mastectomy. Can be go for the breast conserving, but it is very rare cases, in small cases, small breast. And yeah. So the so the mastectomy, large tumor, and for the large tumor, yeah. So as we discussed these points here already. As I mentioned here. So if it is large tumor, central tumor, and it is a small breast, so we cannot do conserving surgery in this, because so we have to go for the mastectomy, right? And if it is a large tumor, so we cannot go for the breast conserving. We have to go for the mastectomy because it's a large tumor, so we have to remove that, right? And then we go for the radiotherapy, as we discussed before, that especially patient with the breast conserving surgery like white local excision in young patients, especially, we offer patient radiotherapy to reduce the risk of recurrence, right? And yeah, what are the other conditions for the radiotherapy? If tumor is grade 3 tumor, more than 4 centimeter, lymphovascular invasion, more than 3 lymph nodes in axilla are present. So we go for the radiotherapy. This is the criteria for the radiotherapy. When we start chemotherapy, whether the patient is young and premenopausal, again, lymph nodes are positive, lymphovascular invasion, grade 3, tumor is more than 3 centimeter. But patient is estrogen receptor negative. So we go for the chemotherapy, right? If patient is estrogen receptor positive, we go for the hormonal therapy. Again, depending on premenopausal woman and menopausal woman. Right? So if it is premenopausal woman, we go for the tamoxifen, which is a selective estrogen receptor modulator. What it does, how it works? It works by binding to the estrogen receptor and inhibiting binding of the estrogen receptor to their receptor site. So it basically antagonizes the estrogen at their receptor, and it is mostly given into the premenopausal women, because premenopausal women, there is increased production of the estrogen. So the best thing is to stop binding of the estrogen to their receptor. Postmenopausal women, we give aromatase inhibitor. How it works? It inhibits aromatase enzyme, right, and prevent local peripheral conversion of the androgens into the estrogen, right? Prevent peripheral conversion of androgens to estrogen, right? Thus reducing the estrogen, decreasing the availability, and then decreasing the size of the, which result in the decreasing in size of the tumor and helping in curing the tumor. Yeah. But in premenopausal women, when we give tamoxifen, so in breast cancer, it helps treating the breast cancer. But on the other hand, it increases estrogen in circulation, which can result in endometrial carcinoma, right? So because so there is a side effect of the tamoxifen. Okay. The most important thing, what are the good prognostic when the patient can receive the hormonal therapy, and what is the when it is in the best prognosis? So if patient is estrogen receptor positive, progesterone receptor positive, and HER2 receptor negative. If HER2 receptor is positive, it is a bad prognosis. In this condition, we give patient transvastatin or Herceptin. So how it works? It works by binding to the HER2 receptor, right? It blocks the HER2 receptors and prevent the further um, uh, formation or production of the HER2. So it blocks the HER2 receptors. Yep. Okay. After the surgery, breast surgery, definitely we are going for the reconstruction, breast reconstruction. So it can be done by using leg dorsi flap. It can be done by using TRAM, which is transverse rectus abdominis muscle. Okay. So we use the leg dorsi flap, and flaps can be pedicled and free. So it can be pedicled and free. Pedicled, it contains its own blood supply. With that, free is depending on the location where it has to be placed. So it depends on that blood supply. So this is TRAM is transverse rectus abdominis flap, right? So two types of flap. Okay. What are the complications? The complications are, this, it's very common. So the first of all, the common can result in infection. Yeah. Because of the axillary lymph nodes clearance, it results in the lymphedema, development of the seroma, right? And we have to treat accordingly. What are the other conditions? Can result in the nerve injuries. It can be long thoracic nerve injury, intercostobrachial nerve injury, and thoracodorsal. These are the three important nerves which can be injured during the breast surgeries and axillary dissection. So long thoracic can result in winging of the scapula. Intercostobrachial result in the paresthesia and numbness of the armpit, and thoracodorsal trunk is mostly supplying the lead dorsi. So there will be no functional loss, but it can we can lose the flap if we later on want to use the lead dorsi. So yeah. Okay. There is one thing regarding the yeah. So lymph nodes, as we discussed here, the lymph nodes, there are three groups, and how we do the lymph node clearance. So we have to look for two things. If during the ultrasound, right? So for the lymph nodes, first of all, when we see that there is suspicious, so we look for the ultrasound and see whether the lymph nodes are palpable, right? So if ultrasound shows abnormality and lymph nodes are palpable, right? So we straight go for the biopsy and axillary lymph node clearance. This is one point, right? If ultrasound shows no abnormality plus lymph nodes are not palpable, what we do? We go for the sentinel lymph node biopsy. Then we see if sentinel lymph node is whether it is positive or negative. If it is positive, we go for the axillary lymph node dissection or clearance, right? And if it is not, then no axillary lymph node dissection or clearance. Got it? So there are two conditions here. So whenever we are assessing the nodal status, so we have to look for right. So if on ultrasound there is abnormality and lymph nodes are palpable, right? We'll take biopsy and straight lymph node clearance or dissection. Axillary lymph node clearance or dissection. If no abnormality, lymph nodes are not palpable, right? Then we will go for the sentinel lymph node biopsy and see whether sentinel lymph node biopsy is positive or negative. If it is positive, axillary lymph node dissection. If not, no dissection. Yeah. And then according to that, we will go for the clearance, and we discussed the clearance already. And then the treatment option. White local excision is always patient followed by the radiotherapy. Right? Especially in young patient to reduce the risk of the local recurrence. Another conditions we've discussed already. When to give hormonal therapy, what are the complications, which nerves are more prone to injure. We discussed all these things. So for the next lecture, see you guys again. Have a good day. Thank you. Bye.